Good morning, everyone. All right, now I need to do sharing, right?
Good morning. Are you okay? Are you having any issues?
Yeah, the screen here was locked, so I had to restart the computer. Just a second, just trying to share my screen and then we're ready to go. Thank you for your patience. Okay, so
You gotta get to your PowerPoint.
yeah, it was open,
Was it
but
pulled
I
up?
made sure that I have that open before. So now to get from here to there, this one, I think, share.
Do you want to put it in presentation?
Yeah.
And then I think if you do that, you have to re-share it with the right window.
I do.
Yeah,
Um,
usually.
It looks fine now. It looks
Yes.
good.
Cool.
Alrighty, I put the first few slides are just to kind of keep folks entertained while, people are coming in, but essentially, good morning. There's just, some, art-related, tidbits, but, my topic is going to be on, pain and sleep and this reciprocal relationship between both. And so I just wanted to start with, I guess, how far back the pain and sleep are going, and they're going all the way to 1000 BC. But apparently at our own Cleveland Museum of Art, we have this particular statue, the Etruscan, back from before Christ type of era, apparently. About
So Kate, I just want to pause you for a little bit. I just wanted to make sure everybody, on the call or in person know that Kate Yan is one of our sleep fellows. We want to make sure that people know you.
right.
And then so this right now is around halfway through their fellowship, so it's exciting to be listening to them. Last week, for the last couple of weeks, we have been listening to different fellows, and today is Kate. Okay, sorry to interrupt. You may continue. Let's go back to the art.
Thank you, Doctor. Yeah. So you can see this item, which is more or less a replica or an echo to this particular item here. And this is this famous, infamous Sarpedon's crater, made again 500 years before Christ, and it was made to hold about 12 gallons of wine. And even though it was glued together at some point, but it is still there, it is still able to hold things. But essentially, this is the god of sleep, and this is the god of death, and this is the Sarpedon who got injured significantly, as you can see, hemorrhagic shock and all, at the Battle of Troy. And this is Hermes, who is saying, look, guys, you got to take care of this guy. You got to let him pass with dignity and without pain. And so that's why these folks here are involved. But anyway, the story behind this particular, what?
Illegally excavated.
Oh yeah, absolutely. It has such a fascinating story behind it. And so this is, a pretty good read as far as, what can happen to an item of essentially, a chunk of porcelain, not porcelain even, clay, right?
Yeah.
Over time, and how it influenced generation and civilizations and all of that. But and so there's some other things that kind of happened as I was preparing my presentation on pain and sleep, specifically on chronic pain. There's like a huge public outcry out there about what happened to the CEO of the major health insurance company. And there are so many folks out there, especially anesthesia, who would like to express their opinion. on what's right, what's wrong, and also what things kind of like mean, and explain that, you know, this is partially justified, but this is not justified. But anyway, this gentleman here is an anesthesiologist, and he talks a lot about chronic pain and pain management, and he loves to refer to sleep physicians. And then he also had a very good piece, very insightful on fibromyalgia, because this particular pain condition is very difficult to even prepare people for surgery if they have that kind of condition. And then there was a physical therapist who chimed in and explained how horrible failed back surgery syndrome is. And then they started talking about how majority of the people are really not satisfied with how their chronic pain is treatment. Apparently, the satisfaction rate is around 20% or so. And so there's some more of the beautiful art from the Europe area museums and national museums and international museums. This one is here, Museum of American History, Alcyone dreaming, essentially ramming about her husband. But anyway. And this is the contemporary art now. People express how they feel and what they think. And it's just amazing how folks are just fed up with how they cannot afford healthcare and how they are not getting what they're hoping to get. And so it's just will be interesting to see what happens, if anything, as a result of this obviously public outcry. A very unexpected reaction to essentially a murder. And so I don't really have any conflicts to disclose. Like Dr. Ye said, I'm a fellow. I didn't sign up for anything or didn't engage in anything that would put my information or what I'm about to say at any kind of risk or conflict. And the objectives, I'm pretty ambitious here. I don't know how much we're gonna get through in an hour, but we'll just kind of take a look what pain really is and how people look at it. And especially how it is that instead of healing and getting over it in a couple of days, weeks at the most, you then end up with a lifetime of pain and suffering. And then what does sleep have to do with anything? How helpful is it? Is it helpful at all? And when and how? And then also, again, little tidbit on how it is that sleep promotes healing, what it does or why it's necessary, and then look at some PSG findings associated with pain conditions or patients with different conditions and how you can treat one and essentially hurt the other. And then also we'll take a look at the therapeutics or treatment options. And so some basic definitions, there's a big difference between acute and chronic pain. Essentially acute takes weeks to days at the most to resolve, comes on suddenly, usually in response to some sort of injury or acute illness. And it either goes away on its own as body heals itself, or we provide treatment and you respond to treatment and feel better. Now, if something goes wrong or certain processes don't happen in your body, then the pain becomes a chronic venture, and then so it may come on gradual and you may ignore it, be insidious and you may not notice, and then just one day you realize you can't deal with it and you have to try to fix it. But at that point, it kind of solidified itself. And usually at that point, it's hard to say what caused it in the first place. And at that point, it's usually also way out of proportion of what the x-rays show or what skin looks like or anything else of that nature that objectively would tell us, oh, this is really bad. And then, yeah, and we do this and that and 10 other things, and it's still there or worse. And so then there are a couple of other important things, hyperalgesia and allodynia. Hyperalgesia is when a painful stimulus is perceived as really, really painful stimulus. It's just the response is what should be pain 3 out of 10 is 15 out of 10, as some patients say. And then allodynia is somebody touches you or the light, the sunlight touches your skin, and all of a sudden this is extraordinarily painful. So unpainful stimulus perceived as painful. Nociception is essentially how it is that we process information into pain, right? The stimuli could be heat, could be chemical, could be pressure, could be sound, anything. And so we just, our body interprets it, okay, is this danger or is it fine? And then when sensing pain is good for us. It's a communication method between, brain and the rest of the body, important for survival. That's how we avoid tissue damage. And then, so then there is also dysesthesia. And that is not necessarily pain or damage to your tissues, but this is sensation that makes you extremely uncomfortable and seems like it's painful, but it's, it's just extremely bothersome to the individual, unpleasant sensation. And neuropathic pain is just its own animal. It's another word for it is neuralgia. And it's essentially a nerve pain. So it's a disease of the nerves that don't conduct the information to the right places, or they don't do that appropriately. So it malfunctions, it gets damaged, and the signal becomes just inadequate. And then there is referred pain, right? Where you feel pain in the shoulder, but the source is actually somewhere in the chest. So it's very distracting and sometimes very hard to diagnose, because it hurts in one place and we focus on that, but then you have to take a step back and look at the bigger picture and see. So that's another, I would say, complication to the understanding of pain. So we looked at this again, there's just some of the, I like my pictures, but, and so why would you have acute pain? Obviously trauma, all these fractures, dislocations, burns and bruises. You can have a surgery and, hurt from that. You can have these sudden infections in your lungs and your skin and your bone, viscerally. And then there is the heavy pain of childbirth. And so this herpes zoster here below starts as acute pain, but an area of growing research of how this becomes chronic pain and how once you kind of cross that line, it's hard to turn back and reverse it. And so how does conversion of acute pain to chronic happens? So 3 things happen. They're all kind of interrelated. And if you remember from your, first, second year of medical school, there's all these pathways, but kind of starts at the nociceptor, which could be, somewhere superficially, and then go into your spinal cord, and then from spinal cord receptors, it goes up all the way to the brain and the cortex, and then the higher level processing. But so things can go wrong at 3 levels, right? There could be peripheral sensitization, where you step on the nail and obviously signal is sent out all the way to the brain, you pull away, you try to address the injury. But then because of that puncture of the skin, all the different neurotransmitters get sent out, right? All the different infection processing agents and macrophages and so forth, they release their own chemicals. Then your hormonal axis starts to respond to all these events. So entire body is turned on, they're all communicating with each other. But sometimes instead of just going through the cycle of excitement and then coming down, moving on to the next best thing, the body just continues to just overreact. So that's peripheral, right? Central sensitization is when there is a stimulus, but you just need just a tiny bit of a volume for a body to perceive this is extremely loud, right? So, and that usually happens like right here at the dorsal horn. And usually it just would not subside, right? There's a prolonged electrophysiological discharge. This is exaggerated response. And so it just, instead of filtering it out, it just keeps it on. And so then there's a descending modulation. This involves these interneurons and glial cells, all the descending inhibitory influences. And so these are the areas that kind of filter all of this out. The periaqueductal gray, rostral medulla, so if these guys here do not figure it out, the end result is hyperalgesia and allodynia. And so this kind of just shows all the different chemicals, just basic things, metabolic components, receptors, all the things that we use on a daily basis in our body, right? GCPRs and bradykinins and hydrogens and prostaglandins, TNF alphas, interleukins, all of that stuff, plus our serotonins, norepinephrines, all of these guys just recruited to respond to this crisis. And so again, noxious stimulus, phase 1 activation, right? Impulse conduction, synaptic transmission, just excitation of things from the bottom going up to the top. And then phase 2 is the modulation. Yeah, we got your signal, but is this crisis or is this, just, something routine that we just need to address? Another local attack. Modulation. So this is when peripheral and central sensitization happens. And then at that point, certain things start to get canceled, and then there is the descending facilitation inhibition, disinhibition happens. And phase 3 is modification. This is more of a long-term phenomenon. And this kind of involves the gene expression, phenotype changes, stem cell differentiation, neuroplasticity, changes in your brain and your neurons, all of that. That's more of like a strategic response here, right? So, and then these are all the conditions. This is your patient comes in, right? When you look at the past medical history, do they have these things? Chances are you have this chronic pain on your hands and the insomnia or the sleepiness. And you gotta have to figure out, are you addressing this first, or addressing insomnia first, or and there's just or are you addressing sleepiness kind of like symptomatically, and then you're addressing the underlying cause? I mean, you should do that at the same time, but then there were different studies on how sometimes you just need to tackle sleep. Let people sleep at whatever cost it is. And then you can address, let's say, depression. Or some people say, no, you have to work on the mood, sleep will come naturally. So ongoing debate on that one. But anyway, so these are all the things that you can see. Most of them are autoimmune, right? Chronic pain. A lot of them are neurologic. A lot of them are, some of them are cancer. Some of them are musculoskeletal pain from, injury, trauma. Some of the things are just, congenital malformations. And what's interesting that we're all kind of in this era of nerve stimulation, and so all these different implants for various reasons. And so apparently this stimulator here is that this essentially implanted in your spinal cord, and you activate that and you dose adjust it and all of that. But it even treats claudication from peripheral vascular disease. I thought that was just pretty, or nocturnal angina pectoris. So apparently, or neuropathic pain from diabetes. So it's just, interesting how everything could be almost everything could be treated. Let's see. So pain types, it's important to recognize that your normal or, exaggerated response, nociceptive pain is very different from neuropathic pain. And also cancer pain, it's its own distinct entity. Different neurotransmitters are involved. So, for example, your ouch to trauma is you will have, if you measure it in the spinal cord, right? In the CSF, you will notice an increase in substance P, GPCR, CGRP, sorry, protein kinase C, and substance P. Now, if it's neuropathic pain, then there will be decrease in substance P and CGRP, and there will be instead increase in ghrelin and neuropeptide Y, and you will see that in the spinal cord and at the afferent neurons. And then cancer pain, it will have none of these markers, right? Instead, you will see massive astrocyte hypertrophy. There will be like really no neuronal loss, as opposed to these guys here. And then there will be this neuronal expression of CFOS increased instead. And there's going to be dimorphin immunoreactive neurons near the cancer lesion. That's going to be the major point to kind of try to knock out. So here's a question. This is a gentleman. This is inspired by my VA case, by the way, where I got a referral, but I'll tell you later. I'm not going to give this away. So this gentleman here, 42-year-old man, he has hypertension, coronary artery disease, diabetes, hip osteoarthritis. He also smoked. And so he comes to our clinic and he says, look, I've been awakening every night with pain. I can't sleep because of this pain, and I can't fall asleep because of this pain. And so where does it, start? And so it starts here in the left chest, and doctor, it freaks me out. What if it's a heart attack, right? Because it radiates to mid-sternum right there. And so, and then he says, well, my pain is sharp. And it just doesn't let go for, 30 minutes, sometimes an hour and a half. And then he says, it's really bad, doctor. It's 9 out of 10. And when I had a heart attack, it was 10 out of 10. So I'm really scared. And so then he says, look, the only thing that I know that makes it worse is when I had a bad day at work, and then it's just really bad. And then somehow I noticed a belching kind of when I wake up, I belch it. Gets better, and I sit there for an hour, let it go, and then I can fall asleep after this. And then he says, it occurs about an hour, maybe 2 hours after I fall asleep. And I also have a hip pain, so that's also a problem. But it's just hard to fall asleep, but once I fall asleep, it's okay. And that's because I take naproxen before I go to bed. And then he says, and so now really bad time is awful. It's just pain before I go to bed, pain when I fall asleep. And so what is it that is causing his pain and lack of sleep? See? That's right. So it is. So the clue here was the timing, right? So, and this is when they wake up. And another hint that I gave from my patients at the VA was the belching relieves it, right? And so, yeah, they wake up hungry, or they wake up because of this sharp pain. After we fall asleep, usually about 2 hours into it. At the same time, early morning, and so that kind of pattern gives it away. If it were bone cancer, then it kind of be more ongoing this whole time, day and night. Could be waxing waning, but it wouldn't be specific time like that. And then, I didn't, if I put nocturnal angina there, that would make it hard, but stable angina, obviously, we know didn't show any of those features. And then arthritis, whether it's osteoarthritis or rheumatoid arthritis, you would have certain morning symptoms that make your day really hard in the morning. And then as you go along, it would either get worse or get better, but. And then fibromyalgia, they don't really complain of sharp pain, right? They would complain to you of non-refreshing sleep first, and then this pain everywhere all the time next. So, just a little tidbit on nocturnal angina. And there was this very interesting study, there's a spike, right? Very interesting study on how, if you have princemetal angina, but you are a healthy individual, you're gonna be fine. You may wake up from pain, but you're gonna go right back to sleep because there is really not a significant myocardial ischemia. Folks that are having an awakening from nocturnal angina because of the myocardial ischemia, because of the sleep apnea, because they have an underlying coronary artery disease, they're the ones that are going to have pretty significant consequences. And there's the folks that could be, whose pain could be relieved with CPAP.
It's pretest probability for sleep apnea.
Yeah, right. I think the sensitivity is very high, and the way that this gentleman, I don't know which study it was, very, very sensitive. So, and that's another study that was done, that was just interesting, Dr. Stroll was mentioning, 1986. And this is in Britain, and that was more of an international study here. Not a very large sample size, but look how long ago they already established this. And then there's a couple of interesting tidbits from GI and sleep. This patient that was in the multiple choice question, as I said, as an inspiration from a VA patient who was referred to us by gastroenterology, and he comes in with all the symptoms, and I was like, what am I gonna do for you, for your GERD? But, and so, here's just a case that was published in one of our ASM journals. And this is not your typical GERD, this is a laryngeal related acid reflux. And so, diagnosed essentially with sleep type of, with a polysomnography, but it's also a little bit of a DISE going on here as well. But essentially it was saying that you can see on in your channels how anytime you have a pain, there's impedance increase. But the bottom line here is that after ENT doc treated this laryngeal dysfunction, the person experienced significantly, the AHI decreased. So his sleep apnea burden decreased significantly. And then in this case, this gentleman here, another case, where he was experiencing these hiccups, worse during the day, a little bit better at night, but just would not stop. A patient's chest was hurting from constant, disruption like this. And so he was on PPIs, but that wasn't, particularly helping. He just couldn't figure out what's going on. But even on polysomnography, you could see, this is a 30-second epic, that these are the hiccups here. In this particular case, the gentleman was determined to have obstructive sleep apnea. He was starting on CPAP, and now his GERD is better. So how does this work? There is the intrathoracic pressure, right? So CPAP alters the esophageal function by increasing the intrathoracic pressure. It has this compressing effect on the esophagus. Then the pressure gradient is decreased. So the diaphragm doesn't have to contract as violently. And then it also, CPAP also increases basal, lowers esophageal sphincter pressure. gastric pressure. So this whole tube is kind of gets optimized. But, and so, yeah. Even though there are some reports where CPAP makes your GERD worse, but in a lot of cases it makes it better. But essentially, you have GERD, maybe CPAP is one of your treatments. Now, sleep and pain. So I put this picture of the Siamese twins is for us to essentially remember that the same neurotransmitters are involved in modulating sleep and modulating pain. It's just amazing how they're all riding, the same train, just, kind of like in the different compartments, depending on what time it is. And so some of the tidbits here that some of them I will support with studies and some are just wanted you kind of to take away, and due to lack of time, we're not gonna approve it. And so reciprocal relationship, pain makes, interferes with sleep, and then lack of sleep makes pain worse. How does it do it? There is this nociceptive pathway upregulation, like I said, shared chemicals, neurotransmitters. And then what are those things? There is the opioid pathway, there's monoaminergic pathway, they are rexinergic, interestingly enough. Obviously, its own immune pathway, interleukins and such. Melatonin pathway is its own animal. And then there is this becoming very, very popular in research, this endocannabinoid neuromodulation. And then obviously, as always, hypothalamus, pituitary, adrenal axis, and all of your hormones that regulate your response to stress or body needs. And then there's the adenosine and the nitric oxide signaling components. So many systems involved, a lot of them interact with each other or send messages to each other, codepend. And a lot of them are just doing their things in a silo, which could be a problem sometimes. And so, if you do not sleep, or you sleep poorly, so not enough sleep versus poor sleep quality. And so most importantly, this opioid pathway, and specifically descending pain inhibition, gets disrupted. And then the release of monoaminergic system, serotonins, norepinephrines, dopamines get dysregulated and act on their own things at their own time. And then your pain, instead of going away, just gets amplified. And circadian rhythm is also a factor here, but we'll touch upon it a little bit later. And so one of the interesting studies was how they took rats and they sleep deprived them. And specifically, they just woke them up before they went into REM to deprive them of REM and see what happened to their pain level. And so how it is that they did that, they they sleep deprived them, and then they kind of measure how they would, I guess, detect heat.
Wasn't
Was it
people. Feel better.
right? This particular, so they did that on rats first, then, I guess they found volunteers, they did that on people as well. But, ethical considerations, but, and so, they definitely noticed that people also report such a significant increase in pain perception if you deprive them of sleep, and specifically REM. And
So the rat is a tail flip, the human is just a finger on a hot plate, and when you take it off.
Right, so, and they just,
Yeah, so it's the
they
same
can't
thing.
do anything too drastic with humans. You can only test certain pain responses and pain pathways. Yeah, and so this particular study here in life sciences talks about, stem cells and tissue healing and how it is we rebuild our tissues in response to injury, surgery, tissue damage, disease or from trauma. And so what they were trying to say is it's the circadian rhythm of when things happen. Right, so for the show to start, right, there needs to be a starting time, and then there need to be certain props, and so if you never know when the show is supposed to start and when the people are coming, the circadian rhythm kind of tells the body when to start, who to recruit when, and how much time you have to rebuild this particular or assist this particular organ system versus the other one, prioritize things. And if the bad time is all over the place, then a lot of these functions simply get delayed or canceled or rescheduled and then never done. And that's why body has to figure out how to prioritize what's left in the reserve, and certain things just do not get addressed. That's pretty much, just a very simple fifth grader overview of this. And so melatonin is now becoming more and more important in neuro regeneration, in prevention of neurodegeneration and response to pain, and many other healing properties in the body. Cortisol, kind of tied to explaining how cortisol, other than your obviously sympathetic drive, how it impacts other biological processes. But that's a good article to read, which would be in my references. And then some other, takeaways here, fun facts. So narcolepsy and insomnia and pain, all very closely related. So the nociception and insomnia, right? They're all driven by adenosine, nitric oxide, and orexin signaling. So it's not just orexin signaling. And then these particular pathways are involved in this immune inflammatory cascade. So orexin neuron depletion and the T cell production of pro-inflammatory cytokines. So this all started some time ago. And so chances are this condition you have now, this narcolepsy, is a result of something that happened to you a long time ago. And now your body is in this state of inflammation where certain neurological pathways got impaired. And then neuropathic patients have interesting regulation of pain through opioid pathway and orexin pathway. And those are completely independent on how it is that they regulate response to pain, hyperalgesia and allodynia. And a little bit more melatonin. Again, this guy is this kind of like controller board apparently for endorphins, GABA, opioid, and nitric oxide, arginine pathways. It's in the middle and regulating them all. And so we prescribe it a lot, and we just don't know a lot of things that it does. We just know it helps at this point in time. And so also dysregulation of HPA axis responses. We know cortisol homeostasis, inflammatory cascade regulation. And so you can see every chronic pain syndrome would have a dysregulation of this HPA axis. So endocrinology and sleep and pain management, these are all the departments that should be talking to each other. Rheumatoid arthritis, apparently, and the migraines, are not that different from fibromyalgia that we, for the longest time, believed was a made-up disorder, or we thought, oh, this is just too much, out of proportion, and this is just something people use to condition to get out of things. But it has a real scientific basis, turns out. And so, we talked about this a little bit, but ultimately the takeaway here is that chronic deficient sleep increases risk of development of chronic heart disease and has cardiovascular, metabolic, neurodegenerative, and chronic pain condition effect. So this was an interesting study in 2018 in Brazil, where they were looking at people with type 1 and type 2 narcolepsy. And what they established is that 3 out of 4 of these patients had a significant chronic pain condition or chronic pain that was really like unknown etiology. They couldn't, there was so much workup before that, and still they couldn't figure out where it is it's coming from. And so the study kind of draws attention to how these are comorbidities in narcolepsy, and how if you treat sleep in these patients, you also treat pain, or vice versa. In people who do not have narcolepsy, if you treat them with medications that kind of address, that work on narcolepsy, you treat pain. So fibromyalgia, just a little bit about it, kind of how it works. So some people say, oh, it's from stress, and it's because you were born with these faulty genes. Specifically, there's the genes that regulate serotonin receptor polymorphism, OMT gene, and so then you just don't respond to stress appropriately, and then you have this autonomic dysfunction that kind of goes with it. And so you're exposed to a lot of stress, boom, you have fibromyalgia later because of the central sensitization. It's a very interesting mechanism that is now being addressed. And that's why these folks, it's just, they're difficult to put down. So they're put down for anesthesia for surgery, right? Or they need a different anesthetic than the rest of us. And so some people say, oh, this has something to do with the HPA axis, and this is the growth hormone. And then people said, well, this is also because they don't sleep, and that's kind of like this vicious circle where you don't sleep, you don't get growth hormone release in time in sufficient quantity, then you don't have normal muscle mass, and then you don't have your regeneration. And then, so you end up with this exaggerated abnormal pain perception. And then we have different treatments. So we have opioids, and we have, we know that opioids and Tylenol essentially do not work. And then we don't like amitriptyline for fibromyalgia anymore because of its side effects. And we know that very specific SNRIs, duloxetine, milnacipran, work on it. Gabapentin, pregabalin seem to work on it. And then there's medicine here that's available in Europe and not here. It seems to be also very effective, reboxetine. But now folks are kind of also adding or switching to this nabilone, which is essentially a CBD gummy in a way. And then there's the ketamine pain clinic approach. And then the sodium oxybates for fibromyalgia. You treat sleep, you treat pain. And this is again, he kind of explains the difficulties with anesthesia. This lady is a rheumatologist. She says, doesn't matter what we prescribe. If you don't figure out what to do in the bedroom, how to sleep, it's just going to be difficult to feel better. This study was interesting when they essentially tried sodium oxybates on people with fibromyalgia, and about 6 grams per night was very effective. And so this is fatigue top part, and this is pain. And you notice that response to pain at 6 grams was very consistent and significant. And fatigue, I don't know. So when these folks woke up, they're like, well, do you have more energy? It's like, not really, but I feel less pain. So that was interesting. That this could be a treatment. And we'll skip this one, but the question itself, but you can see all this like alpha intrusions associated with fibromyalgia. And then apparently you can diagnose, if you don't know why it is you see all these arousals and all these intrusions, what is it that they have? They say they don't have anything other than hypertension. Well, you can actually look at certain frequency on EEG and diagnose patients with specificity of 85 with fibromyalgia just from their sleep study. And this is like a little distraction. How much time do we have left?
10 minutes.
10 minutes, yeah. So a little kind of like transition here. This is from my culture. This is one of the favorite things that I grew up on. Bublik or obvaranak in, let's say, like Poland or Latvia. But in Russia, this is bublik. And the bublik almost always comes with the poppy seed on it. Now, there's the big one. And then there's the average size, and there's the little one, right? Like 3 little bears, right? Goldilocks story. But this one, the big one, it's kind of, you cut it sideways like a bagel and you put butter on it, or you can put jam on it, and you kind of like, this is your mid-afternoon tea, or it's a little snack. This is not breakfast food, right? Like bagel here. And then there is the medium size, don't have much experience with that, but this is what's called sushka. And this is essentially an extremely dehydrated tiny bagel, right? And obviously it has poppies on it. And I have just with fond memories of childhood where I would walk from like my middle school was about an hour away from my home, so it was a very long walk. And so first stop was the bakery store or the bread store, and this was 5 kopecks, so I'd get this bublik. And as I walk, I eat that and process the events of the day. But we had, so this was perceived just an a spice, right, to use, nothing dangerous. And then this became a problem where then the fate of the bublik was just put in jeopardy with the poppy wars and the opium wars. And so then it was just that. But anyway, you make it, the trick, yeah, I mean, that's unfortunate because it just changed the flavor. But anyway. And so the way that you make it is you have to dip it in water and boiling water. It's like parboil for about 10 to 20 seconds. And that gives it that kind of like very thick texture rather than being spongy. It's like thick and chewy. So now let's just quickly finish with patients who have chronic pain, really significant pain, and who are on opiates. And so we are back to Hypnos, and we have Thanatos, the god of sleep, god of death. Hypnos gave birth to Morpheus. Morpheus is known to be essentially a god who regulates REM sleep and communicates to you in sleep. Very powerful. And also somehow associated with opiate-induced sleep. Now, who's gonna win here? This is a very interesting kind of interpretation from, over 2,000 years ago, where you can get peace, but this peace may come at a price, right? So tug of war. Another multiple choice question, 40-year-old male. He has pancreatic cancer. He's referred to you by oncology. And why is he at your clinic? Daytime sleepiness. He's snoring at night. He assessed score 16 out of 24, really sleepy. So they do a sleep study. We'll look at some epics here. And then question is, what is he on? Obviously, he's on something for this pancreatic cancer. pregabalin, gabapentin, tramadol, and methadone. And so this is his tracing in non-REM sleep, right? And you see all of these like events here. What are those? So look at this. And then this is now a REM sleep, right? REM sleep. Shouldn't you be obstructing more? Look how like much better this is, right? So it's Morpheus to the rescue. So just skipping all because we don't have time, but essentially it's methadone, right? Methadone is the worst of all the opioids when it comes to central sleep apnea, right? And so what happens with that? So on PESG, you will see the slow respiratory rate, ataxic type of breathing. You will see central apneas. So there's going to be cycle length variation, and the tidal volume would be also reduced. So becomes more and more common. In fact, we just had a webinar last week by Dr. Jahaveri on this very similar topic of opioid-induced central sleep apnea. And so with that, you can also have central sleep apnea. When you have OSA and CSA together, that's a complex sleep apnea. And you would have hypoventilation during daytime and during sleep. And then if you do measure CO2, it's really not going to be that bad. If you have your TCO2 monitor, it's going to be in the like 50, 52, maybe even 45. But then there will still be hyperventilation present. Now, if it was present during the night, then it's most likely to be present during the day. If it were present during the day, then it's going to get even worse during the night. So there's just kind of like this perpetuating type of effect. And so, which can then lead to fatal outcomes. But usually, these things also get revealed after you get diagnosed with OSA using your HSAT, your watch pad, right? Oh, we have OSA, there's some other things in here, but let's just address OSA. And then you address this, and then all of a sudden you have all these centrals. Where is this coming from? So could be coming from a, cardiovascular and neurologic event, or could be coming from your med list, right? And so there was a study that was done at the private clinic, funny enough, but essentially what the gentleman found in Webster is that 75% of the patients had, almost all of them had some sort of sleep apnea, and they, depending on what opioid they were on, and around the clock in this case means like 4 times per day and more, and then, or a patch, fentanyl patch. And so methadone was the one that was consistently giving you centrals. And so that's the one to look at. Now, if you had benzos on board, plus opiates, and you had heart failure and COPD, this is really bad news. And this is like, this is the patient population that Dr. Stroll gets. Every week, there's at least one patient with narcolepsy and pain.
That's what I got last week.
And this lady, who just came to us after being in the hospital, right? And she is on the benzos and the and the opiates, and she has heart failure, and she has COPD on 5 liters, 4 liters of oxygen, and nothing is taken care of. But anyway, let's take a look at the opioid-induced sleep apnea, and just a little bit more. So one thing to take away, that these people would have normal total sleep time. They will have fewer arousals and have this M3, like they sleep really well, right? And then you will notice that the AHI is higher in non-REM sleep versus in REM sleep. That's kind of another giveaway, but this is also kind of a finding that led to the fact that CPAP is just not going to work for these folks. If they have this data sleepiness with PAP, well, it has to be a special kind of PAP, right? Because you're going to be switching. Your demands are going to be different depending on what stage of sleep you're in. And so some of the treatments, it's also, some of this is kind of borrowed from Dr. Ari's studies. And so you will notice that when you review a sleep list, these people are either on baclofen or they're on valproic acid for seizures, or they're bipolar or something else, or they are also on this pretty significant dose of gabapentin. Funny enough, everybody has gabapentin now. And then if they're on sodium oxybate, that could be an issue as well. And then funny enough, ticagrelor, right? Who would think? But this guy changes your chemosensitivity at like a blood vessel level, carotid sinus and such a ventilatory response to carbon dioxide at the blood vessel level that would then cause pretty significant sleep apnea. But so they work differently on how they cause this central sleep apnea. So mu opioid receptors for methadone, right? And then GABA receptors is how baclofen and valproic acid would do it. And so let's see, there's some tidbits for anesthesia, like they have their own recommendations for people with CSA. They're scared of those folks. And then this is also from this webinar. How can you tell, is your central caused by meds or is your central caused by heart failure? And this is ataxic breathing that he compared to Morbid's type 2, saying that's kind of, it's there, and then longer drop, or it just goes, and then there's a skip. So it's not going to be as beautiful and symmetrical as Cheyne-Stokes breathing. And so how can you tackle the CSA when you have pain? Well, you should reduce narcotic dose. If you get people off opiates, this will resolve, but these folks are not gonna do it most of the time, especially cancer folks. And then you can add stimulants to kind of keep them awake during the day. And then you can hook them up to ASV, and you need to pay attention to the EBAP here. You know, get them through the night that way. And we can also use PAP with backup rates, but looks like everybody's favoring ASV. And this is one of the many research papers on how ASV is better. And there will be many more according to Jahaveri and company. And so then you can use acetazolamide if you don't have any of those fancy equipment, let's say a low resource country, or you don't have the remedy device available to you. So last resort is apparently acetazolamide is better than any of the other potential treatments.